All right, I think we'll go ahead and get started here. Good afternoon, everyone. Thank you for joining us for the MDH Stroke Program Education Series today. We have an exciting presentation from Dr. Bethany Sabol at mHealth Fairview University of Minnesota Medical Center. We will get to hear about the postpartum risks associated with hypertensive disorders of pregnancy, including stroke and heart health, and learn how remote blood pressure monitoring supports better maternal outcomes. So before we get started, I'll cover a few tips to navigate Teams. Today's webinar is live and recorded. As usual, your lines and videos have been muted upon entry. You can interact with us today using the team features. Share a reaction by clicking on the smiley face for emoji options. Feel free to ask questions along the way by typing them in the chat throughout the presentation. We will keep track of these questions and we'll try to address them at the end of the presentation or within the webinar follow-up email. If you are having any issues accessing Teams chat when it is time for Q&A after the presentation, please raise your hand and we can unmute your line. Teams has built-in closed captioning you can turn on from the meeting controls. To use live captions, go to your meeting controls at the top of the screen and select More, and then navigate to Language and Speech, and then select Turn on or off live captions. Here's our agenda and learning objectives for today. I will start with a few stroke program updates and then turn it over to Dr. Sabol. We'll end with some time for Q&A with our presenter today. So we have several stroke program updates for you. The first is that the MDH Stroke team was very excited to hear that Minnesota received another year of funding through CDC's CoverDell grant. Thank you to those who continue to advocate for the program and support us. Just last month, we released an MDH Stroke Program Stroke Coordinator 101 training series, which is available on our Stroke Program YouTube channel. This educational opportunity was developed in collaboration with Jen Wells-Pittman and is relevant to all levels of stroke coordinators, especially those new to the role. The 2025 Minnesota Statewide Stroke Conference will take place on Thursday, November 6th at the Heritage Center of Brooklyn Center. Conference registration will open in September. The Conference Planning Committee is also looking for presenters and proposals. The deadline to submit is August 15th. Michelle will add the link to submit your presentation proposal in the chat for you if you are interested. We are still accepting applications for quality improvement projects for this year until August 29th. Just a reminder, we are accepting applications for stroke-focused quality improvement projects across the stroke care continuum, not just hospitals. And if you have any questions, you can reach out to Allie. And then please check your inboxes to complete the annual hospital survey sent by our team just yesterday. Your responses to this 5 to 10 minute survey each year help us stay up to date on stroke care practices at your hospitals and inform our activities for the coming year. Thank you for your participation on this. And then finally, there is no scheduled webinar in August, so we hope you are enjoying summer and taking those well-deserved vacations. All right, now I am excited to welcome our presenter today, Dr. Sabol. We will be transitioning over to her slides, so just bear with us for 1 second while we get that set up.
Can you guys see everything okay?
Yeah, looks great.
Okay, perfect. Good afternoon, and thank you so much to the Minnesota Department of Health Stroke Education Series for the opportunity to present today. I'm Bethany Sabol. I'm a maternal fetal medicine physician by training, and I also am the physician lead for our HOPE PP program, which I'm going to talk to you more about today. So today I plan to review what hypertensive disorders of pregnancy are and the unique risks that they pose, particularly for the postpartum period, including an increased risk of stroke. And we'll also spend time discussing the current evidence for postpartum remote blood pressure monitoring programs and why implementing these programs are so important for maternal health. I also plan to describe in detail kind of what our program is and provide some practical information on how home blood pressure monitoring programs can be implemented in different healthcare settings. And finally, end our discussion today with the impact that hypertensive disorders of pregnancy have on long-term cardiovascular health and what opportunities we have to improve maternal cardiovascular outcomes. The rate of maternal mortality in this country is unacceptably high, with significant racial inequities and a lot almost entirely preventable. Both nationally and here in Minnesota, the postpartum time period represents one of the highest risk times for maternal death, with over 50% of deaths happening after delivery. And maternal mortality is really just the tip of the iceberg. It's estimated that for every one maternal death, there are 70 to 80 cases of severe maternal morbidity, which can result in lasting maternal impacts. Hypertension and hypertensive disorders of pregnancy, or HDP, as you might hear me refer to it, and their associated complications are a leading cause of both maternal morbidity and mortality. HDP is an umbrella term used to describe high blood pressure conditions that can impact a pregnant person either during pregnancy or following birth. This includes conditions like chronic or pre-existing hypertension, as well as preeclampsia, which is a high blood pressure disorder that develops during pregnancy or in the weeks following delivery. These disorders can lead to significant complications, including severe hypertension, end organ damage, heart attack, and stroke. They are also associated with an increased risk of lifelong development of chronic hypertension and cardiovascular disease. Last year, there were 3.62 million births in the United States. 1 in 7 of those birthing people developed a hypertensive disorder of pregnancy. That's over 500,000 birthing people at risk annually. And we see these increased rates of HDP reflected in our local birthing populations. At my hospital system, Health Fairview, we do approximately 13,000 deliveries annually across the state of Minnesota, and we are seeing rates of HDP at our birthing hospitals complicate between 20 to 35% of all births. And for these patients with HDP, while delivery is often the first step in reversing the causative process, things can often get worse before they get better, with the postpartum time period being one of the highest risk times for worsening blood pressures, maternal complications, and death. In obstetrics, severe hypertension is the most common complication in this population, both during pregnancy and after birth. And we define severe hypertension in our population as a systolic blood pressure greater than or equal to 160, or a diastolic blood pressure greater than or equal to 110. This threshold was chosen specifically because maternal stroke occurs at lower blood pressure thresholds compared to the rest of the population. Severe hypertension has been identified as the leading cause of hypertension-related morbidity and mortality, particularly due to the increased risk of maternal stroke. In a recent California maternal mortality review report, 61% of preeclampsia-related deaths were attributed to stroke, and 96% of stroke cases were preceded by systolic blood pressure over 160. So while stroke, especially in young people, is a rare event, it can occur in up to 1 in 500 births complicated by a hypertensive disorder of pregnancy, with most strokes occurring within the first 2 weeks postpartum. And these are often missed initially because our patient population data has demonstrated experiences a twofold increased risk of a delayed diagnosis compared to their non-pregnant peers. Because delayed or inadequate treatment of severe hypertension may lead to maternal death, stroke, and other serious complications, acute onset severe hypertension is considered a medical emergency, and achieving timely treatment of severe hypertension has become a leading quality indicator in obstetrics. National, state, and local efforts to treat sustained severe hypertension within 30 to 60 minutes has led to significant reduction in hypertensive-related maternal morbidity and mortality. This data here is from the Illinois State Perinatal Quality Collaborative and has nicely demonstrated that improved treatment of sustained severe hypertension amongst their participating hospitals has led to significant impact on severe maternal morbidity in their state. And here in Minnesota, we are also making headway. The Minnesota Perinatal Quality Collaborative led a hypertension and pregnancy initiative from September of 2021 to August of 2023, with participating teams increasing the percentage of birthing individuals with timely treatment of severe hypertension from 55% prior to the initiative to 71%. Within our own hospital system, mHealth Fairview, sustained timely treatment of severe hypertension has been a point of pride for us, as we've sustained over 80% compliance at all 9 of our birthing hospitals over the last 5 years. In addition to the risks associated with sustained severe hypertension, we also know that hypertensive disorders of pregnancy are a risk factor for the development of peripartum cardiomyopathy, which is a leading cause of cardiovascular related mortality postpartum and often occurs over 42 days after delivery. Patient presentations commonly include severe hypertension as a clinical finding. And not only is the postpartum period a high-risk time for maternal adverse outcomes, severe hypertension is also a leading driver of hospital readmissions, which are disruptive for patients and their families and costly to the system. We know from experience that blood pressures peak 3 to 6 days following delivery, and this timing often correlates with the first few days that a patient is back at home following birth. In our system, over 90% of our hospital readmissions for hypertension occur within the first week postpartum, and most commonly for new severe hypertension. So, knowing that the significant risks associated with hypertensive disorders of pregnancy and severe hypertension, and understanding that those risks do not end after delivery, how do we alter our care models to make our patients safer? We have an all hands on deck approach to timely treatment of severe hypertension prior to birth and in the hospital setting, and frequent, consistent care antenatally. But where is that safety net upon discharge? To reduce the risk for patients, the American College of Obstetrics and Gynecology recommends that all patients with HDP have a blood pressure check within 3 to 5 days of hospital discharge. This recommendation, however, is insufficient at reducing risk due to poor visit attendance and many patients actually experiencing severe hypertension and requiring readmission prior to the scheduled visit. The US is also the only major industrialized country that lacks a universal postpartum follow-up system. And so, recognizing the lack of surveillance in this increasingly high-risk time, ACOG has updated guidance to reflect the importance of enhanced engagement with patients in the postpartum period, including a call to incorporate innovative interventions for risk reduction, including suggesting using remote healthcare interventions and telemedicine to help facilitate care. Postpartum remote blood pressure monitoring was created to begin to fill this void and simultaneously attempt to reduce risks while also reducing barriers. So, over the last 10 years, multiple hospital groups across the country have developed a range of telehealth-based postpartum home blood pressure monitoring programs. These programs have been studied in prospective and randomized controlled trials with promising results. They've demonstrated improved adherence to ACOG's blood pressure monitoring guidelines, exceeding over 90% compliance, with high rates of patient satisfaction, with over 95% preferring postpartum telehealth to an in-person visit. These programs also allow for increased surveillance of blood pressures and maternal symptoms during this high-risk time. For every 100 patients who participate in home monitoring, there are 1 to 2 fewer readmissions, 5 to 8 more postpartum care visits, and 20 more patients initiated on potentially life-saving antihypertensive therapies, with significant reductions in relative risks of adverse outcomes compared to non-participating patients. These programs resulted in more than a 1.5-fold increase in antihypertensive use compared to standard office management, and closer surveillance in identifying risk, with reports of up to 15 to 26% of patients experiencing severe hypertension that may have otherwise gone undetected. This extra surveillance has also resulted in a reduction in postpartum readmissions and racial inequities in blood pressure ascertainment, all while also demonstrating cost effectiveness. Studies have demonstrated that telehealth is cost-effective up to $420 per person and remain cost-effective so long as the postpartum readmission rate at a hospital is 3% or higher compared to standard monitoring, with the estimated cost savings of $93 per patient. Within mHealth Fairview, our baseline data as a system back in 2021 and 2022 showed that we had significant room for improvement, but remote monitoring alone was not sufficient to address our needs and identified opportunities at our hospital. So we set off on an ambitious journey to design a maternal hypertension care map that would provide evidence-based recommendations and improvements to our care in this population, starting at preconception through the 4th trimester. This is just an example of the things that we undertook as part of this really ambitious care map. It spanned interventions in the preconception, prenatal, intrapartum, postpartum, and interpregnancy intervals, and incorporated our emergency services. I'm going to highlight some of the key components of our care map that I believe are vital initial workflows and processes to have in place prior to launching a postpartum remote blood pressure monitoring program. The first is to establish a standardized approach to management of postpartum hypertension. This included developing a standard threshold for treatment, as well as a standard titration protocol and criteria for safe discharge from the hospital. While tighter control of postpartum blood pressures have become relatively standard, back when we started this work, it was a novel idea, and our kind of governing body, ACOG, was still recommending not initiating antihypertensive therapy in the postpartum period until blood pressures reached a threshold of 150 over 100. We aligned our postpartum management instead with the recommendations from the AHA and ACC, targeting lower blood pressure thresholds for medication initiation and titration in the postpartum period with a goal of less than 140 over 90. While there's still limited evidence looking at target blood pressure goals in the postpartum period, acceptance to tighter control postpartum and optimization of blood pressures to kind of have a goal of meeting non-pregnant standards has become much more widely accepted. A recent study also evaluated the impact on even tighter blood pressure thresholds and found a 68% reduction in emergency department visits without evidence of serious adverse maternal outcomes related to tighter control. So I wouldn't be surprised if we even tried to align with blood pressure goals of less than 130 over 80, consistent with our non-pregnant population. So not only did we need to start blood pressure medications at lower thresholds, but we also needed to standardize our approach to how we increase and decrease medications and which medications are preferred as first-line agents. We did this by creating standardized algorithms for recommended treatment for postpartum blood pressures. Part of this work also included obtaining more blood pressure readings for our population. Through this work, we realized that postpartum vitals for all patients were only happening every 8 hours in the hospital. And so we knew that we needed more information for this at-risk population. So instead adopted obtaining blood pressure readings every 4 hours. And then we also wanted to ensure that we were sending patients home when they were medically ready and implemented a standard discharge criteria in line with the California Maternal Quality Collaborative's updated guidance to ensure that patients were leaving our hospital had not had a severe range blood pressure within 24 hours prior to discharge. Another critical aspect of this work was ensuring that patients with hypertensive disorders of pregnancy discharge with blood pressure cuffs, allowing patients to continue to monitor their blood pressures closely at home following discharge. We partnered with our durable medical equipment supplier to develop a process to distribute blood pressure cuffs during their delivery admission, ensuring that patients left our hospital with a device in hand. And then we also developed an easy-to-read blood pressure card that was affixed to all blood pressure cuffs and translated in our 5 most common languages so that patients could have a quick reference as to what their blood pressures meant and what we would recommend that they do in response. To accompany the blood pressure cards and cuffs, we also work with our patient education to create and revise patient education materials on the warning signs and symptoms of preeclampsia, how to monitor blood pressures from home, and information on the long-term risks associated with hypertensive disorders of pregnancy. And as I said before, we had all of these materials translated into Spanish, Somali, Hmong, Karen, and Vietnamese, which are our 5 most commonly used languages other than English. And we also know that despite best intentions, that the stack of ABS paperwork we all receive is often never looked at again and instead ends up in yesterday's mail under the counter, crumpled under a car seat. So in addition to the patient education given in the ABS, we really wanted our patients to leave the hospital with something more visible and more easily accessible to be referenced. So we created a magnet specific for preeclampsia warning signs and symptoms and included a helpful script for what they could say when reaching out to care providers if they developed a concern. Having put so much work into these educational materials and engaging our postpartum nursing teams on practice education and teach back, we wanted to ensure that what we were doing was effective in reaching patients and improving their understanding of preeclampsia and its risks. We developed a hypertensive disorder of pregnancy knowledge survey and administered the survey to patients during pregnancy and their delivery admission, and then administered the same survey after they discharged and had received our discharge education bundle. We approached 109 patients to participate, 65% completed the pre-survey, and 40 completed both surveys. Overall, knowledge scores improved significantly between the 2 time points. with patients demonstrating significant improvements in the knowledge of diagnosis, symptom identification, and understanding blood pressure numbers. 63% of respondents reported feeling more aware of their own health after receiving the education, and over half felt more control of their health. And we've also switched from a standard 1-week follow-up blood pressure check to a blood pressure check within 3 to 5 days postpartum and implemented a home care visiting system for all patients. And we continue to monitor our work. The blue line here indicates our rate of patients discharging with a blood pressure cuff, and the orange line shows how well we are doing following our standard protocols for postpartum blood pressure measurement, with the smaller numbers indicating better compliance, as it's looking at a failure to initiate medications for people with elevated blood pressures in the 24 hours prior to discharge. So we want to see smaller numbers there. So it took us a long time to develop and implement all of those changes. But while we were working hard to lay the groundwork, we were also simultaneously working with our Epic IT analysts to build our integrated home blood pressure monitoring program. And by November 15th, 2023, we were ready to launch. Home observation of postpartum elevated blood pressure, or HOPE-BP, is the remote monitoring program we created to meet the needs of our patients with hypertensive disorders of pregnancy after discharging from our hospital. So I'm going to spend a little bit of time now discussing how we designed our program, how it works, and how the program is impacting outcomes for our patients, and what they think of the program, and then end with kind of where we plan to go from here. Our HOPE-BP program is available to all patients who deliver at the University of Minnesota Medical Center, discharging with a diagnosis of chronic hypertension or a hypertensive disorder of pregnancy, whose preferred language in Epic is English, and who have an active MyChart account. Eligible patients are identified during their delivery admission by the care team and offered enrollment. Upon hospital discharge, they're enrolled and prompted to submit blood pressures twice daily through MyChart Care Companion. When they submit a blood pressure reading, they receive immediate feedback on what their blood pressure value means, and our dedicated HOPE-BP team reviews and responds to blood pressures daily. The team may initiate or titrate antihypertensive medications to keep blood pressure control optimal, or identify at-risk patients who need further evaluation or hospital care. This is the monitoring dashboard that we created to facilitate quick triage and efficient workflows. And this is our standard algorithm for medication initiation and titration to help aid outpatient medication management. And we coupled this with a standing nursing order. At completion of the 6-week program, a handoff letter is provided to the patient and their care team, which summarizes their time in the program and educates on the long-term risks of hypertension and cardiovascular disease, in addition to recommendations around health maintenance in the context of this diagnosis. This is an example of what that guidance looks like. I cannot emphasize enough how much a program like HOPE-BP is a team effort. This program is only successful because of the dedication from our inpatient providers and nursing teams who recommend our program to patients and aid in their enrollment, and because of our amazing team of maternal fetal medicine nurses who closely monitor and care for these patients postpartum. This is just a brief snapshot of the roles integral to this program's success and the Epic tools that we built to support the work. So the inpatient OB provider really determines patient eligibility for the program and then places an order to enroll. And we integrated that order into our discharge panel. The inpatient OB nurse then provides education on how to use that blood pressure cuff and assists with the enrollment after hospital discharge has been complete. Once that has occurred, our MFM nurse coordinators provide introduction to the program via phone, monitor our dashboard and in-basket daily during the week for alerts and patient questions. Then they manage medications using our standardized protocols and escalate as needed to the maternal fetal medicine provider, myself often, as to what medications potentially need to be adjusted. And then they follow up with patients when no blood pressures are submitted in a specific time frame, and then create the handoff letter at the end of the program. We created Epic smart phrases, smart text, smart sets, and dashboards and reporting workbench reports to help facilitate this work. Myself, as the MFM provider, helps manage medications for patients that are not eligible for the standing order protocols or help address any escalations or questions our nursing team may have. And then our primary OB providers or PCPs receive that handoff letter at the end of the program to summarize a patient's participation. And again, this is just the nursing tasks. So they get alerts, red or yellow alerts based on blood pressures and the blood pressure severity with kind of a recommended time frame and how quickly they respond to those. So our red alerts, our goal is to address those during business hours within 60 minutes. And then our yellow alerts, our goal is to try to address those as quickly as possible, but give them a little bit more time to kind of look at those as they're coming in. Those yellow alerts come in if we have mild range blood pressures or low blood pressures not entered within 48 hours or 14 days, or if they're ending the program still on medications. After hours, we have our red alerts go. We provide a phone number for the patient immediately. If they were to enter severe range blood pressure, that directs them to call labor and delivery. And then we work hand in hand with our inpatient providers to help field those calls after hours. Our Hope BP team has also been integral in helping us optimize the program. So we found that kind of patients were getting a lot of information at the time of discharge and maybe still a little bit unclear as to what Hope BP was and what it was supposed to do for them after leaving the hospital. And so we changed our program to optimize and improve engagement by integrating a welcome nursing call on the first day of the program to kind of again go over the purpose of the program and answer any questions the patient may have. Similarly, we realized that kind of a touch point at 14 days of disengagement was too long. And so we created a new active touch point within 48 hours of a patient disengaging from the program to help kind of reintegrate them into the program if desired. We also take a really active approach to blood pressure surveillance and management. So we frequently evaluate blood pressures for timely medication initiation and titration. Oftentimes, if they have 2 or more blood pressures kind of above our goal, we'll be looking at medication adjustment potentially if they're taking medications as prescribed. And we track those changes in medication so we can understand how much our nurses are integrating and collaborating with patients to make medication changes. And then we're also really looking to educate the primary team kind of about any Hope BP concerns. So we realized that we needed to kind of do a little bit more collaboration because they're continuing to see their primary OB for all their standard care. And we want to make sure that their team is looped in with the changes that we're making in case it's applicable to their additional visits. So as I mentioned, our program went live in November of 2023 at our main university campus, which performs approximately 2,200 deliveries a year, of which approximately 30 to 35% of our delivering population has a hypertensive disorder of pregnancy. So of the 982 patients with hypertensive disorders of pregnancy who deliver at our hospital since we went live, and this data runs through March, 853 or 87% were eligible to participate, with 677 or 79% ultimately enrolling and participating. Of those who desired enrollment, 87% enrolled on the day of discharge as intended, and 87% recorded a blood pressure on the first day, with 89% recording a blood pressure within 72 hours of hospital discharge in accordance with ACOG recommendations. We had 20 readmissions in the 18 months. Most were due to worsening disease, and 60% occurred overnight or on the weekends when we didn't have RN coverage for the program. And we had a 78% attendance rate at our 6-week postpartum visit, which was a significant increase from prior to when we launched this program. And patients have demonstrated active and ongoing engagement for the entire 6 weeks of the program and have showed really excellent blood pressure outcomes. We believe that our model of remote monitoring, in addition to RN support and standardized management of blood pressures, has resulted in most patients having blood pressures in the optimal range throughout the program, with only 6% having experienced severe range blood pressures. This is in comparison to the rates of 15 to 26% reported by other home monitoring programs, some of which do not have RN support. With regards to hospital readmissions, our postpartum readmission rate due to hypertension for this population is relatively low compared to nationally reported rates of 5 to 10%. Prior to implementation, our readmission rate was 3.1%, with a year-to-date since we went live decreasing to 2.9%. But as I mentioned before, when we look deeper into those readmissions, for patients participating, we really found 2 main themes. The vast majority of readmissions occurred in patients with worsening disease, so the close surveillance of our program allowed for timely triage and readmission for patients to receive the medical attention that they needed. And the second theme was that 60% of the 20 readmissions occurred when we had unsupported hours. And we think this really speaks to the value of our centralized nursing team and the individualized yet standard management approach for this patient population. And so what are people saying? We conducted 24 post-participation phone surveys to get patient feedback on how our program was going right after we launched, and found that the feedback was overwhelmingly positive. So not only are patients engaged, but they genuinely value Hope BP as part of their postpartum experience. I won't read you all of these quotes, but here are just a few things about what people have said about the experience in the program. And I think the last quote really exemplifies what our program is designed to do. A patient said, "I'm very thankful for the program. My blood pressure was so high and I might not have known it. This program probably saved my life." These patients also provided us with very helpful feedback about how we can make Hope BP even better. Common feedback focused on the timing of blood pressure entry being too restrictive, desiring clear guidance on blood pressures and program details, and not being sure who to reach out to with questions. We've taken this feedback to heart. We immediately incorporated that welcome phone call I mentioned on the patient's first day to help reorient them to tasks, set expectations, and provide key phone numbers for contact, and answer any questions they may have. We're also actively working to continue to partner with patients to further optimize and improve in this patient-centered way. So for anyone on this call who is considering a program like this for your patients, there are a few key considerations when starting out. One is, what do you want your patient experience to be, and what can your organization support, and what does that interface look like? Will you be able to integrate with your EHR, and how does inpatient outpatient workflow support your project? 3, thinking about what you will do with blood pressure information that patients report, and will you want to look at outcomes at all for either quality or research? And then 4, and lastly, how can you afford a program and can it be sustainable? I think the key to our success was a strong partnership with stakeholders at all levels. We had ongoing collaboration between the inpatient and outpatient spaces with strong framework to build upon. And so taking these implementation lessons into account, we're really looking forward to the future of Hope BP and what we can do to continue to improve and expand our program. We really first and foremost want to optimize the patient experience. Based on the patient feedback we've received, we plan to improve how patients interact with our program by specifically adding materials to their MyChartCare companion landing page, hopefully expanding the time in which blood pressures can be input, and considering device integration and improved access to patient education resources. We're also hoping that the future Epic capabilities to MyChartCare companion will improve our patient enrollment workflows, allowing us to enroll before hospital discharge, as well as working to enhance provider access to patient data reporting and outcomes. We're also looking to expand our program, both in terms of coverage, with expanded nursing hours to include evening and weekends, as well as the number of patients we serve. We aim to bring Hope BP to our 8 other birthing hospitals across the state of Minnesota, and hopefully work with Epic to take what we have created and make it accessible to other obstetrical hospitals who utilize Epic as their EMR. And finally, we want to push for a more inclusive format, as inequities in birth outcomes based on race are unacceptable. We feel like it's critically important to bring Hope BP to non-English speaking patients, and are looking for ways to translate the program in order to make it accessible to at least 3 of our most common non-English speaking languages in the coming year. And we're continuing to look for opportunities to strengthen wraparound care of patients through efforts to move postpartum hypertension triage to L&D for assessment instead of having to send patients through the ED, and establishing a Hope BP transitional clinic as a joint effort with cardiology to expand monitoring through 12 weeks postpartum, or 12 months postpartum, to optimize cardiovascular health and promote ongoing cardiac care for this at-risk population. Because while what home monitoring programs do to reduce immediate risks and improve outcomes is really exciting, I think a potentially more meaningful impact is on blood pressures long-term. 1/3 of patients with HDP remain on antihypertensives at 6 weeks postpartum, and up to 45% of patients with HDP go on to develop chronic hypertension within the first year following delivery, with up to 1 in 5 patients eventually developing chronic hypertension, which without these programs may go unrecognized and untreated. But Hope BP and other programs like it are a powerful way of ongoing engagement with patients at elevated risk for adverse outcomes. Recent studies have shown that postpartum home blood pressure monitoring combined with medication self-management and telehealth support leads to lower blood pressures not only at 6 to 9 months, but even up to 4 years postpartum compared to with usual postpartum care, and associated with improved measures of cardiac structure and function. Patients who have been randomized to home self-management demonstrated persistently lower diastolic blood pressures at 6 months postpartum, even off blood pressure lowering agents. And this difference persisted and was even more significant with the intervention arm demonstrating a 7 millimeter of mercury lower diastolic blood pressure compared to the control arm. A 7 to 8 millimeter difference in 24-hour ambulatory diastolic blood pressures would be expected to reduce cardiovascular risk by over 30%, and therefore have a really meaningful impact on the increased incidence of cardiovascular and cerebrovascular disease seen following a hypertensive disorder of pregnancy. Critically, this study highlights that there really is a window postpartum where a relatively affordable and clinically translatable process of home blood pressure monitoring and management can impact long-term blood pressure trajectories for women after a hypertensive disorder of pregnancy and reduce the later burden of cardiovascular and cerebrovascular disease. And the importance of this cannot be understated because cardiovascular disease is the #1 cause of death in women and the leading cause of death in pregnant and postpartum birthing people. Despite this, cardiovascular disease in women remains understudied, underrecognized, underdiagnosed, and undertreated. In May of 2022, there was a publication in the Journal of American College of Cardiology that utilized data from the Nurses' Health Study and demonstrated that birthing people who experienced a hypertensive disorder of pregnancy had a 63% increased risk of developing cardiovascular disease later in life. And that's even after controlling for factors that may result in an increased risk of developing hypertension during pregnancy or having a heart attack or a stroke later in life, such as being obese or having a strong family history of cardiovascular disease. And these strong associations were still true. So for women with gestational hypertension, which is a form of HDP, there was a 41% increased risk of cardiovascular disease, and they were more likely to have a stroke approximately 30 years after their first pregnancy compared to normotensive women. And women with preeclampsia had a 72% increased risk of cardiovascular disease and were more likely to have a coronary artery event, such as a heart attack, as early as 10 years after their first pregnancy. In this study, gestational hypertension was more strongly associated with the development of chronic hypertension and a stroke, whereas preeclampsia was more strongly associated with the development of heart failure and coronary artery disease. And when discussing lifelong cardiovascular risks after hypertensive disorders of pregnancy, it's important to keep in mind that while stroke and coronary artery disease are the most common, it's also associated with an increased risk of heart failure, aortic stenosis, and mitral regurgitation. And when looking at the risk of cardiovascular disease later in life for this population, researchers in this study found that post-pregnancy cardiometabolic risk factors such as obesity, type 2 diabetes, and chronic hypertension did explain most of the increased cardiovascular risk observed among women with gestational hypertension or preeclampsia. And in fact, chronic hypertension was the largest contributor of all and accounted for 81% of increased cardiovascular disease risks among people who had gestational hypertension and 48% of increased risk among patients with preeclampsia. Most women who experienced a hypertensive disorder of pregnancy develop chronic hypertension in years or decades after giving birth. However, it's estimated that only 33% of those women were on antihypertensives as indicated. So this data really suggests that the #1 thing that we can do to reduce the risk of cardiovascular disease is to get blood pressure under control. And over the last 5 years, there does seem to have been an increase in interest and momentum from primary care and cardiology colleagues in better partnering to understand how pregnancy-related adverse outcomes can impact lifelong health and how we can better partner to optimize those outcomes. The American College of Cardiology, in collaboration with the American College of Cardiology Cardio-Obstetrics section, did recently develop a comprehensive postpartum hypertension clinic developmental toolkit, which is really user-friendly and can help aid primary care and cardiology colleagues as to how to manage patients after a hypertensive disorder of pregnancy to reduce cardiovascular risk long-term. And this is really vitally important because it's estimated that up to 67% of women see their OBGYN as their sole healthcare provider. And so it's really kind of our job as OBGYN as part of the healthcare community to correctly help diagnose and treat patients with chronic hypertension, as well as to help identify modifiable risk factors that might increase their risk of lifelong cardiovascular disease and help implement lifestyle changes to mitigate these modifiable risks. We need to implement things like early screening and monitoring to target blood pressure, cholesterol, glucose levels, and BMI, which might help to delay or possibly even prevent future cardiovascular events, as well as providing patients education on really what that history of hypertensive disorders of pregnancy means for them in terms of their lifelong health and well-being. And then really our job to help connect them with primary care and cardiology colleagues when necessary and help explain what those risks are. These healthcare transitions can really act as important times to relay just how significant risks of adverse pregnancy outcomes are as they relate to lifelong risk, because it's reported that less than 10% of non-OBGYNs counsel patients on how adverse pregnancy outcomes do impact their future health. But I'm hopeful that these partnerships can help improve that statistic. One critical piece that cannot be overlooked for this population is lipid assessment. It's recommended that for patients with a history of HDP, a lipid profile be performed after 12 weeks postpartum, if not performed in in 1 year prior to pregnancy. And per the 2018 ACC and AHA lipid guidelines, it's reasonable to consider initiation of statin therapy in individuals who are over 40 years of age with a calculated 10-year ASCVD risk above 5%, or if they have additional indications for statin therapy. I do want to point out that conditions specific to women, including preeclampsia, is not included into the calculator, but is listed as an ASCVD risk enhancer. Additionally, all patients with an onset of hypertension prior to the age of 30 should be screened for secondary causes of hypertension, and I think we have room to improve in this metric. And we need to continue to work on messaging. So many patients are unaware of the potential long-term impact that hypertensive disorders of pregnancy have for their cardiovascular health and well-being. So we really have to utilize this time in which our pregnant and postpartum patients access care more than any other times in their lives to develop personalized heart disease prevention and monitoring strategies that really emphasize optimization of their health during the interpregnancy interval and that bridge them to primary care, recognizing that we need to partner differently in order to meet the needs of our patients long-term. So I hope you are leaving today with a better understanding of hypertensive disorders of pregnancy and their impact on the birthing population, how we can do more to support this population in the postpartum period, and just how remote blood pressure monitoring programs can be one of those ways, and that the risk and our responsibility extends long past the 6-week postpartum visit. So thank you so much, and I would be happy to take any questions.
Hi there. Thank you so much, Dr. Sabol. That was incredible information to share with our group today and for all your advocacy and hard work for birthing people and women. Thank you. This is a great time to open up for some questions. You can feel free to drop them in the chat here and we can address them. I can help facilitate that, or you could also raise your hand and we can unmute you. Friends, I am not seeing anything pop in unless I'm missing. I'm popping over to the Q&A section as well. Maybe it was just so much to digest and chew on. I have just maybe a couple comments. People are usually really excited to have the slide deck. Is that something that can be shared? Wonderful. Jamie will
Yeah,
send
of
that out
course.
with a follow-up. Great.
Mhm.
Allie has a question. Could you speak to how you got buy-in for the Hope BP project?
I think just a lot of persistence. I think I wore people down. No, but when I came to Health Fairview in 2020, there was really a big focus on readmission rates. I think everybody was frustrated seeing patients bounce back so quickly and so often. So I think there really was energy initially amongst our unit, at least, in kind of doing something to help solve that problem. And I had come from an institution in my fellowship at WashU, I started a home blood pressure monitoring program there. And so by starting it and running it, I really had firsthand experience just how powerful it could be in improving those outcomes. So I think having that background and experience, I was able to speak to the benefits in a way that I think really just carried a lot of weight. And so I kind of utilized kind of what we were already seeing for patients in our outcomes and to help engage kind of some of those key leadership. But I think really engaging operational leadership, nursing leadership at both your inpatient and outpatient levels, I think is key. And then it really kind of took those people identifying that it was an issue and helping advocate to kind of the higher ups that this was kind of a key priority, I think was what really kind of helped drove us to be successful. I will say we are still really working on trying to get buy-in and engagement for the expansion. So currently it's only available at the university. We're in a little bit of a stall and trying to expand it more broadly. So if I find other ways to be successful in that regard, I can definitely circle back with this team. But I think engaging and really trying to kind of give patient level examples as to how impactful programs like this can be. And then there is just such a dearth of data, or there's such great amount of data now to really show how beneficial they are. I think that helps make that argument.
Thank you. There is a couple others here. Do you have a couple more minutes, Dr. Sabol?
I do. Yeah.
Okay,
No, I'm
great.
okay.
Great presentation is a comment, and wondering if you feel there are any impacts on insurance costs, such as life insurance with the earlier diagnosis.
That's a great question and something I haven't thought of before. I would say that, we're not typically making a new diagnosis during the monitoring program itself. So patients are either already diagnosed with a hypertensive disorder before enrollment into our program. And we don't typically, yes, people who are still on the program on meds, at 6 weeks postpartum do then go on to have a diagnosis of chronic hypertension. But I haven't really seen that become an issue in terms of life insurance. And I think that the potential benefit of having that diagnosis earlier and getting treatment potentially saves them from kind of more significant diagnoses from an insurance standpoint, at least like a life insurance standpoint, at least later on, because we do know that there is really significant severe hypertension that can happen as early as kind of those first few months to a year after delivery if untreated and undiagnosed.
Thanks. A few more here. Are the home BP readings discussed with the patient during follow-up appointments and also used in care planning?
Yeah, so our the way that it's integrated into our EHR is that it's just in a flow sheet. So our providers who take care of these patients for their routine care at like 2 or 6 weeks have access to all of their blood pressures. They can also see all the interactions in Epic between our nursing team and the patient in terms of medication adjustments. They don't get kind of a detailed summary till the end of the program, but it is all in the EHR available for them to review. And it's not uncommon that we'll have patients, for example, go into a 2 week visit and their blood pressure in office is lower than maybe what they recently reported. And it's not uncommon for our care teams to kind of be constantly in contact of, hey, their blood pressure was a little lower. They maybe had a symptom. We went ahead and reduced them just so that, that our team, when they're then talking to them or reviewing their blood pressures later on, know that an adjustment was made. So there's a lot of good care collaboration that happens between our teams.
Great. A couple other comments. Agreed. Truly incredible dedication to the program. Fantastic work. You noted on a slide there were 20 readmissions postpartum. Was this prior to the program initiation?
No, the 20 readmissions were from November of 2023 through March of 2025.
Okay. So that
And
answers
we
that
had,
secondary. Okay.
yeah, and had more readmissions other than that, but were the 20 specific to patients actively participating in the program.
Perfect. Thanks for clarifying. A question about the BP cuffs. What is
Mhm.
the durable medical equipment piece to get the cuffs for patients on discharge?
Yeah, so we just stock them on our postpartum units, and then we fill out a DME form similar to like if you patients were discharging with breast pumps. And so it gets billed to the insurance on the back end. So we're not like waiting for insurance approval or like having them like have to go somewhere else to get a cuff. We felt like that was going to be a huge barrier to patients actually participating. So we just give them a cuff at the time of discharge, and then bill the insurance on the back end the same way we would bill breast pumps.
Got it. Final comment here, question. Great cross-fertilization with the stroke team. Besides our awareness of the program and the risks to postpartum individuals, what other measures can we proactively undertake to get the word out?
Thank you for that. Yeah, I think really just awareness that stroke can happen in this population and that severe blood pressures should be identified. And that I think too, right? Like everybody just has the hat on of what they're used to taking care of. And we fully understand that like blood pressures that we are like, this is severe hypertension, this is emergency. Everybody else in the adult population is like, oh, that's not that bad. So I think it's really kind of really trying to make sure that we're asking patients like, have you recently delivered? Like, were you pregnant recently? Are you currently pregnant? And then really understanding that because of the physiology of pregnancy and postpartum, blood pressures at lower thresholds can pose increased risk, and to be thinking about stroke in that context when patients present with symptoms or with severe hypertension as something that you need to be considering.
Awesome. Thank you so much for that. Okay. I think in respect of time, I think we had this go to 12:45. So I think I will, unless any other questions stir up, I'll pass it back to Jamie for the closing slide and evaluation comments.
Yeah, thanks, Michelle. And thank you, Dr. Sabol. It was a wonderful presentation. Here is the closing slide with the QR code. Here, I'll get this up here. All right, here is that QR code that will direct you to the survey for the contact hours, or you can click the survey link that will be put in the chat. Upon completion of the evaluation, you will receive 0.75 contact hours for today's webinar. Before we close, I would like to extend a huge thank you to Dr. Sabol and her team for their time and expertise on this topic today. This is such a great program that I hope others are able to take away some learnings to their hospitals as well. To everyone else joining today, thanks for all you do. Have a great rest of your day, and we will see you in September. Thank you.
Thank you guys so much.